Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, and we are so proud to be the convener for International NASH Day. And I'm very excited to bring you this very important panel on pediatric NASH, or NASH in children, as part of our educational series today. Nonalcoholic steatohepatitis, or NASH, is a serious disease affecting more than 115 million people. We know that the prevalence of NASH is rising with rates of obesity and type 2 diabetes, and that children are affected. Unfortunately, obesity in children is a global problem. If trends continue, more children and adolescents will be overweight than underweight by the year 2022, which is just next year. The pandemic intensified the risk factors for pediatric NASH, with children deprived of physical activity in some cases, or nutritional meals that would have been delivered to schools. More than ever, NASH requires further attention, education, and action by all of us, and that reach needs to extend further. So the Global Liver Institute, all through today, June 10th, or if you're watching this afterwards, we're welcome for that as well. But on this day, on International NASH Day, we're bringing the entire world together, and NASH around the world is our theme. Please use the hashtag NASH Day as you communicate with us on social media and talk about these great panels. So we also are very honored to have the endorsement of more than 15 medical societies and the World Health Organization. And I would particularly want to thank AASLD, the American Association for the Study of the Liver, and EASL, the European Association for the Study of the Liver. But I want to thank every medical society, every physician, clinician, and researcher who has supported the Global Liver Institute and International NASH Day this year more than any other time and moment. And so without further ado, I'd love to introduce this fantastic panel. I have with me Samar Ibrahim. She is many, many things, as you can see her on this slide. She is a member of the steering committee of the Pediatric Special Interest Group at AASLD. She is a consultant in the Division of Pediatric Gastroenterology and Hepatology at Mayo in Rochester, Minnesota. Alisha Mavis comes to us from Duke University in Durham, North Carolina. She is an assistant professor of pediatrics and a pediatric hepatologist in the Division of Gastroenterology, Hepatology, and Nutrition, which will be an important aspect of our conversation today. Jennifer Pandan is an assistant professor at the University of Pennsylvania, pediatric gastroenterologist and physician nutrition specialist. She's also director of the Non-Alcoholic Fatty Liver Disease Clinic at CHOP, the Children's Hospital of Philadelphia, where my husband used to be on faculty, so I'm very excited about that. And of course, that's in Philadelphia, Pennsylvania. And we have with us as a very special guest, Joanna Ralston, who is CEO of the World Obesity Federation. She's on the steering group for NCD, that's Non-Communicable Disease Civil Society Working Group at the World Health Organization, usually based in London, although where are any of us based at this point in the pandemic besides Zoom? So ladies, welcome. So Dr. Ibrahim, I will address the first question to you. Most people don't realize that children can get liver disease. Can you just tell us about the state of liver disease in children and the common diseases that occur in pediatric cases?
Sure. So liver disease can happen in children as well as in adults. Maybe the category of liver disease that happen in pediatric are different because there are more metabolic liver disease, congenital liver disease compared to the one diagnosed in adults. But since our focus is NASH, non-alcoholic fatty liver disease is actually the most common liver disease in pediatric as in adults. And as you just mentioned, Donna, there are emerging literature showing that the global risk of NASH have increased significantly over the last decade, and there was an annual increase in incidence of 1.3 1.5%, which is kind of really alarming. So children, the issue with liver disease in children, it can be asymptomatic. So children might not manifest a lot of symptoms, especially if the cause is fatty liver disease. But this condition is not benign and it's not slowly progressive. So it's a real condition that people need to be aware about, and especially primary physician, families, and the general population speaking in general. So that's part of the NASH awareness and what you're doing today also.
Thank you. Dr. Pandan, and I'm going to say this right by the time we finish this panel. It's my morning tongue twister, but I thank you for being here. Tell us about what you experience and what you see in your clinic.
So I'm a pediatric gastroenterologist, and so I have a clinic that is just where I see like liver disease in general, and then we have a NASH program where we see patients specifically just for that problem. And I see patients who typically come and they're asymptomatic, like Dr. Ibrahim was saying. They're identified on screening, usually by their pediatrician because they're overweight or obese, and they have no symptoms. So the buy-in that I see from the families and the children is quite low, unfortunately, because they don't understand this is a real disease and a real pathology that can progress to advanced liver disease. The other way that they're identified too is by imaging. So they usually have abdominal pain, they get a CT scan or an ultrasound, and they have hepatic steatosis seen on imaging. So they come in for follow-up and they're like, why am I here? I have liver disease? That's impossible. And so the first step is trying to educate them about what is this disease and how important it is, and like, what is the progression?
Dr. Mavis, do you also find that families come in and they resist the thought that their child is overweight to begin with, and that's a problem with that? And liver disease is a shock to people. Can you tell us about your experience in your practice and how you work with families?
Yes, no, just like Dr. Pandan and Dr. Ibrahim addressed, this is where many patients are asymptomatic. And so kids do come into the clinic, and starting with the first thing of addressing overweight or obesity is a tough spot to begin with anyways, especially because many of the family members are overweight or obese as well, but don't consider themselves overweight. So first trying to get them to buy in to understand that their child is overweight, but then also to starting to address, like Dr. Pandan said, about the liver disease and how NASH or NAFLD is a progressive disease and that their child has it is another tough thing. Being down in the South where we have so many food deserts and lack of resources, it's even a bigger issue because once we identify it, then it's trying to get things in place to help the family so that they can actually make the changes they need to. But the first step of educating the family and get them to buy in is the biggest step and the most important one.
So, Ms. Ralston, how can you put all of these issues in context from a global perspective? You've been working on the language of obesity, the evidence-based and research in obesity. And so what can we learn from that to help us in addressing NASH?
Well, thank you. Excellent question, Donna. And first of all, it's just such a pleasure to be here and really honored to be part of your International NASH Day, event, which is fantastic to see. I think obesity has some of the same challenges that NASH and NAFLD do in terms of not being understood as diseases, of being really the evidence having really significantly emerged over the last decade or so, but still, playing catch up. And in the case of obesity, there is an enormous amount of sort of misunderstanding and stigma about it. I think obesity is certainly better known than NASH and NAFLD, and yet not in the ways we want to be known, because it's seen, it continues to struggle with a misperception that it's a matter of individual failure. Sometimes in the case of children, it will be sort of parental fault is the driver of obesity, whereas we know it's much greater than that, much more due to the obesogenic environment. Genetics play a role, so does sort of prenatal perinatal care. So there's all these different elements that contribute to it. So in terms of there's obviously a very high association between, I think, 60 to 95% between sort of NAFLD and NAFLD and obesity that cuts across adulthood and childhood. I don't have numbers for childhood specific, but I understand they're roughly similar. So that is a that's a challenge as well. But then there's also an opportunity for us to really recognize how much we have in common, how interrelated we are, and how many opportunities there are to try to address this in a concerted way. I can go on for a long time about what WHO is doing about it, but I think why don't we get the conversation going, and then I can bring in some WHO and UN targets around this that might be helpful to give some framing. The only other thing I just want to quickly mention, one thing that's helping with obesity in terms of improving the understanding is that we use what we call person-first language. So we really use it as a noun rather than adjective. We say person with obesity rather than obese person. It just helps to sort of to really recognize that this is a disease like any other disease, and indeed like NASH, like NAFLD. It's a disease that's affecting in the billions. So it's really important to get the understanding, the narrative right, I suppose, is a good way of looking at it.
And I'm sure that's particularly important with children. You don't want
so.
to label them, you don't want to stigmatize them, you don't want to
Mhm.
have them feel stuck or
Yeah.
traumatized, in this place. And so let's continue on with what exists currently as opportunities to help children with NASH and their families, and then maybe we'll talk about what's on the horizon. But what do you do for children right now? What do you, Dr. Ibrahim, you start? What is current management?
Sure. So the gold standard of treatment for children with NAFLD is lifestyle intervention, weight loss, and diet. So this is going to be the basis. And there is an accountability system. So studies have shown that patients who are followed regularly by either their primary pediatrician or their obesity specialist are more likely to lose weight when they're even on the same lifestyle intervention and exercise program. So this is the mainstay. There are no FDA-approved therapy for NASH in children yet. There are a big study that was done using vitamin E, and the endpoint, which is NASH resolution, was better with vitamin E compared to the other treatment groups. So we use vitamin E in patients with NASH, but the decision to start vitamin E is most of the time based on a biopsy. Because we cannot start some therapy without a clear diagnosis. And NASH, even though it's the most common liver disease, is a diagnosis of exclusion. You exclude every other disease. So we are kind of limited on our therapeutic options for children. I know my colleague in obesity management, they do some other options off label. This is beyond maybe the scope of our talk for obesity management that might have impact on NASH. And there are, as we all know, multiple agents in phase 3 clinical trial, at least 5 of them. One of them is on the horizon also. There are a subset of patients who will benefit from bariatric surgery, but those need to be well selected. And I think Dr. Pingabon and Mavis can speak more about that. But there are very specific criteria to refer a patient to bariatric surgery based on their body mass index and other comorbidities. And even with bariatric surgery, lifestyle intervention is going to continue. It's not a ticket. To be given like a pass from the diet and the and the exercise. Yeah.
So, Dr. Pandan, what does the role of for children in particular? They're growing, and so I can see a parent just saying, "Well, they'll grow out of it." Of a growth spurt. We don't have to deal with it, perhaps. What do you say to those parents about sort of the urgency of treating NASH?
So I tell them, I kind of give them statistics a little bit. So I tell them there is at least 10% of the patient population, has NAFLD, which is a spectrum of disease from accumulation of simple fat, which we call steatosis, to then you go into NASH, which has inflammation, right? So about 25% has NASH and about 15% already has fibrosis. So they're in different stages. The only way we could truly tell which stage they're in is by biopsy, but most people don't want the biopsy in the beginning, of course, and we don't suggest that from the get-go. But I let them know, depending on what age they're in and what stage kind of where they present in terms of their liver enzymes, that this is a disease that's very serious. I love Google in a sense where I can put up this chart where you can see like pictures. So it's like, very easy since I don't draw, but you can see the progression of the disease and I show them that. So it's a visual presentation to them so they understand, because, when you come in and you don't have buy-in and you don't understand why you're here, and most of the time you're sent in by your pediatrician and, they're dragged in by their parents, they don't understand the concept. And then for the parents, what I try to focus on is that I'm not asking your kid to lose X amount of weight. What we're going to focus on is truly lifestyle intervention. I want to figure out what you're eating, what you're doing, how are you sleeping? Like, what's your screen time? And then I tell them, these are the things that we can modify. And based on what you're doing, and I understand your kid is growing, so I don't want him to lose 10 pounds. I want him to maybe stabilize his BMI, depending on what is the goal, what is the age. So there is a goal for each and every patient that I see. And I really focus on behavioral lifestyle change. So that's my first step before I go into more advanced treatments. And like Dr. Ibrahim was saying, because I am trained in obesity medicine, I actually do some off-label medications, but that is never the solution. I don't feel like that is the first step to anybody. So to answer your question, I think it's very individualized. And my goal is, how can I make an impact in your family where you can sustain it for life? It's not just like so that you can lose 10 pounds in the next month, right? So that's not the goal.
Dr. Mavis, I know that you have, a great multidisciplinary team there at Duke. You have everything from nurse practitioners to dietitians to, bariatric surgeons. And so how do you use the entire team to help people and their patients and their families with NAFLD and NASH, and all of their risks also for diabetes and cardiovascular disease?
No, that's an excellent question. So we do have a wonderful multidisciplinary team here at Duke. But it does take a village to help with this and to treat this disease. And so we start in the liver clinic trying to do the education piece. We do have a dietitian that meets with every patient every time they come in. As Dr. Ibrahim was saying, patients have better outcomes if they're more closely followed. And so we try and see them in the clinic fairly regularly with the dietitian meeting with them. With each clinic visit, setting 2 to 3 lifestyle or behavioral modification goals that we can work towards, and then actually ask how they've done at the next visit. Our goal, as Dr. Pandan was saying, was not weight loss as much as let's maintain your weight, but can we get you to make some lifestyle modifications? I do have great endocrinologists that I work with as well. So when they start having the concerns for diabetes or pre-diabetes, that they get them in, and then we're working as a team to go forward with this. As for selecting for bariatric surgery, we have some amazing bariatric surgeons, but it is a very select population in pediatrics that we go for that with psychology involvement, because that still is lifestyle changes and behavior modifications for life. It's not just surrounding the surgery. And so usually it's not until our much older teens, 16, 17, 18 at the earliest, that we're discussing that. But even starting from as young as 5 and 6, when we see some of these kids, it's how do we address behavior modifications, and not just for the patient, but also what can we address for the whole family? Simple things of don't bring the soda in the house if that's an option. If that seems to be one of the problems, let's not buy it, because you can't expect 2 people in the house not to drink it when it's sitting there staring at them.
Right.
And so we really try and focus on behavior modifications that the family can address as well. But every time we leave clinic, it's 2 to 3 goals. And then we address how they handled that at the last, since we last saw them. But referring out to our other subspecialists when needed, for sure.
One of my favorite books is Nudge by Professor Cass Susteen, about, positioning the basket of apples, at the front, and putting, sort of less healthy treats or snacks, further away, and just constructing the environment in a way that helps people make healthy choices. Joanna, is that some of the work that your NCD committee does, or some of the work that the World Obesity Foundation helping to construct environments that are, pro-health, rather than sort of fighting against people and tempting them at every station?
Absolutely. It does differ, sort of country to country a little bit, what the kind of the way things are presented, but certainly obesogenic environments are unfortunately something that exist everywhere. And particularly you go into large urban centers in low and middle income countries, and, cars have, the absence of sort of an urban planning approach has meant there are far fewer places for, sidewalks, for safe places and spaces to play. And the air quality is bad. And all of those things are driving children not having access to physical activity, which plays a huge role in addition to the elements you're describing. We do see, for example, some of the population-based approaches like taxing sugar-sweetened beverages, front of pack labeling on food, particularly the black and white, stop sign approach, which just says high in sugar, high in fats, et cetera. Very simple. Traffic lights are great, but they can get a little complicated because you're like, wait, this is red and this is green, and what do I do with this? The stop sign front of pack labeling, which was really launched in Chile and is now underway in, I think, more than 50 countries, if I'm not mistaken, is a great simple way to support the nudge, I think. While also, some countries, smaller, lower resource countries, there's a lot of aggressive marketing going on without all the nice sort of buffers of the public health approach having a really strong voice. And so I think we need to acknowledge that. And in places like the Pacific Islands, where you have the highest obesity rates in the world, actually, you have issues around trade. And in order to be part of sort of the global trade system, countries have to agree to allow the import of pretty unhealthy products. And so it's a very tricky, just as we see domestically, sometimes the conflicts between commerce and health. That's true at the international level too. I would say it's getting better in terms of recognizing that there needs to be better alignment, but it's not. It's a what they call a wicked problem, very complex, very multi-layered. I think NASH, NAFLD, and obesity all share that kind of complexity. And people want simple solutions. Political leaders want you to say, this is what you do, and then it's done. And it's not like that.
Not like, and I said that's time, but it does seem that drawing together the cardiovascular community, the endocrinology community, and the hepatology community together for the first time, and starting to do in NASH, gives us such an opportunity to approach this as a public health issue that we really haven't had for any other type of liver disease. And so when we think about, working with the NCD working group and positioning for the first time really liver health as part of that whole conversation, how do you see that? How do you see that going forward?
How do I see it? I think it's fantastic. I think having a shared issue like this is fantastic. And we have, it's good because we have the, it also allows it allows the person with lived experience to be at the center in a way, which I think is such an important part of this as well. That sort of, this is the experience, my experience cuts across cardiovascular diabetes, into obesity, of course, cardio, all of those elements coming together. So I think that there's, significant political momentum at the WHO level. Last week, or today, I think is the last day of the World Health Assembly, where the governing body meets, and they passed a diabetes resolution. Did not yet include language on NASH, but it included strong language on obesity, which is going to support the NASH message and effort. And I think it's finding you're not going out in a silo, which is one of the things I admire so much about Global Liver Institute. You're taking a really wonderful holistic approach, which is where the solutions lie. And so saying, well, where do we engage with diabetes, with obesity, with, and that's where finding the common agendas, finding the common, sometimes formal targets, which WHO has adopted, which the UN has adopted, can be a great way of partnering with different disease groups and risk factor groups.
I think it's the only path forward for us, but I also think it provides such a, hopefully a halo effect or for other, for awareness and appreciation of all forms of liver disease. I like to think that, or at least say that, if you have a liver, which is everyone except for a few moments between transplants, that you are at risk of or already have some form of liver disease. And, people need to be aware of that. And we would love them to think of liver health in the same way they think about their heart health or their brain health, and act accordingly. I want to drill down into the impact of this pandemic, particularly on children, but follow along with some of this policy. So, Dr. Ibrahim, what about COVID, with children being out of school and not getting nutritious meals, not having recess, just a whole host of things. How are children, how have they been impacted by COVID? And now are there policies and things that we need to put into place to make sure that they can be as healthy and active as possible?
Sure. So as we are well aware, with COVID and distance learning, the activity level of the children have decreased significantly because they're doing most of their learning through the screen. They're not around and out. So this is a factor. And also the amount of caloric intake per day, I can say for my own children, I'm sure there are studies out there have increased. So these factors were related to the pandemics. And now as things have started to improve, and the hope that vaccine is now approved and running for 12 and older and will be approved for younger age group, this is an opportunity to go back to the regular life. Thing that we can do is mainly through awareness, through like the community and the school system, education about NAFLD and obesity being a disease, modification of the school meal structure or components, so it's more nutritious and less rich in saturated fatty acid and carbs. If you look at that, there was actually a very interesting study a few years ago, and it showed that with the food industry and the increase in the amount of fructose corn syrup and in food, there was a increase in the obesity pandemic. So there is clear association between food components and obesity, and these are where public health policy has to do because this is going to need major changes. This is where I see the opportunity is to have more physical education integrated in the school curriculum. So it's kind of really we are raising, not everybody going to be an athlete, but active students, let's say. And as Joanna just said, having more places for children to play outdoor and be more active. This is going to be through for example, the city layout or within the county. So measures maybe at a higher level that what we can do as physicians, but we are aware about the need of these infrastructures to support elimination or not really reduction of the obesity, NAFLD, and engagement of the community through what we're doing right now, awareness, engagement of the primary physician. These are all things that we can do. I'm not quite sure if I went off track, but
right, because I think liver health policy is food policy. It's exercise and recess and education policy, and it is so much more than just in a way to surround you there at the medical center with a supportive community that is positioned for health. So I think you were spot on with your recommendations. Jennifer, I'd love to ask you about if telehealth was something that you used during the pandemic, and if you think it would persist, and if it helped with access to patients.
Yeah, that was a great question. We were very active in our telehealth efforts, like from the get-go. I mean, CHOP is very supportive in that and trying to get patients what they need. So we were lucky from March, we got that right from the beginning. I feel like it's going to help in a sense moving forward, because a lot of my patients who usually can't make it because on a regular basis without COVID, they don't have a lot of resources. And so to make example, just to see me sometimes in our multidisciplinary clinic, they'll take 2 or 3 buses. And then the parents would have to miss, if not the whole day, like half a day, because just like Dr. Mavis, we have a multidisciplinary clinic where they see a dietitian and they see a physical activity specialist. And so their day is like at least 3 hours when they see us initially for the first visit. And so it's really difficult for them to make all those visits, miss school, parents out of work. So I feel like it plays a big role moving forward in terms of follow-up. I think, of course, I want to see them on their very first visit and give them their education. And if they really can't make even that visit, it's worth at least having a telehealth visit. And I feel compliance in terms of follow-up has increased because it's easier for them to see us. And I'm able to track them closer and give them the support that they need. And if they need the dietitian to be seen, they can do that on a separate visit. That's just a telehealth visit. So we've been a big advocate of continuing those visits moving forward, as long as the government and insurance will pay for it, right?
Well, we work on that.
Yeah, so that would be a move forward.
ACG and AASLD on the telehealth waivers, both audio and video versions, and also the state licensing and being able to render medical care through different telehealth initiatives across state lines. And so I think that is, as a patient who has definitely benefited from that, it is crucially important. And I also think the access that it's giving to, as you said, to people who can't take so much time off from their jobs or have transportation issues, or if we live in rural areas and, driving in Philadelphia may take, several hours. And to be able to access, academic medical center expertise for such a complex disease is really essential for their success. And so I think this is very important as an access and an equity issue for families.
And like to add to Dr. Ibrahim a while ago, it's like we have identified a lot of patients who have food insecurity, even through telehealth, and we're able to send them we have a food pharmacy where we're able to send them vegetables and fruits from our own area and then, to their addresses. So it's kind of a great resource, although it's limited, but it's still something that, usually we can't typically get. So that it's been a big push for both seeing patients, doing follow-ups, more compliance to care, and then also trying to figure out what they need from a day-to-day that we can also outsource.
I think the idea of prescribing food is medicine, prescribing exercise is something that more doctors should do. I think that's fantastic. So Alisha, keeping on this theme of technology, because we've talked a lot about how to reinforce lifestyle changes with patients and families. I know I use mobile apps and, virtual health coaching. Is there a role for technology to help children and families make these lifestyle changes and to stay on track?
Absolutely. As we kind of touched on telehealth, that's been a great area of technology that's been going forward. But we do struggle with it down in my clinic area because we have such a Hispanic population, and telehealth and internet access has been a struggle. That's another thing we need some policy on, that everyone should have access to internet, especially for school and stuff. But the other side of it is some of the things that we're using in clinic is we're actually doing videos with our families in clinic of how to do grocery shopping for the items that we're looking for to stay within a budget. we tell these people you need, fresh fruit, fresh vegetables, lean meat. Those are some of the most expensive things in the supermarket. And so how do we help them address how to actually shop for that and do that as an event? And so we actually do some different videos with them in Spanish and in English addressing, shopping in the supermarket. We have some apps that, we do the steps. And so kids can work on a goal of like how many steps they're going to get a day, just like we all do with our, used to be the pedometer. Now it's all on the phone or your watch,
Right.
which is fantastic. Trying to keep up those exercise minutes. I don't encourage many kids to keep a food log or calorie diary. That's more of an adult thing. But just trying to keep track of how we do it and using some of the videos to learn more, even educate them about NAFLD and NASH and what that is and what is liver disease in pediatrics. And so a lot of YouTube and other sort of videos have been extremely helpful as we go through this. It just comes down to, do our patients have internet access at home, or is this something we can only use with them when they're in the clinic physically?
It does sound like a program of funding as well as policies in need of advancing, because I could see where a certain level of sort of gamification of this. I mean, I do a lot of things for Peloton Badge, and so I would think that children even more so, I would hope that children even more so than me are interested in that sort of setting up a different reward system than food. Rewarding activity, rewarding, social collaboration with your friends, and healthy competitions, and really share this change in sort of orientation of what is fun, what is life about, what is healthy, in the context of their families and friendships as well, I would think would be important. So Joanne, you look like you really wanted to say something. What other things that you've seen have been, really helpful, that, we might help shine a spotlight on or scale. And I'm always thinking about solutions that are as effective in, Seattle as in Senegal, and looking at rates of mobile phone penetration in Africa, and things, putting forward solutions. But what things have worked? Are there programs that people should know about that have been, great case studies or things like that?
That's a great question, and I just was smiling because I love this topic so much, and I just was excited. I can't speak highly enough about all the great work that has gone on. I think I actually want to make one observation about COVID and obesity, which I think is relevant to NASH and NAFLD as well, which is that we're dealing with, in some cases, asymptomatic silent killers, really, but they take a long time to play out. All of a sudden colliding with something that very rapidly, causes hospitalization and death. And that is this, there's been a very high correlation, as I'm sure you know, between severity of obesity and outcomes of COVID. The World Obesity Federation published a report on World Obesity Day, March 4th, that showed that 90% of countries with high rates of COVID complications and death had high rates of obesity. Essentially, and the reverse was true in well too. There was high correlation in low prevalence settings as well. But what that does, and this is sort of a kind of a political calculation, is take something that it's hard to capture the attention of the policymaker over their more condensed time frame that they're trying to get results, and say, no, an unhealthy population is a population that in this and in unfortunately future pandemics is going to have the worst outcomes. I don't think it's quite trickled down yet or trickled out yet to NASH and NAFLD, or at least the evidence. I don't know that it's been really gathered quite yet, although I do know you've done fantastic work making all the linkages. But it's another way of framing this as like we've learned the consequences of populations with these underlying health, in particular, inflammatory states that one has in both obesity and in a portion of the non-alcoholic fatty liver diseases. Is that in and of itself becomes gives a sense of urgency, which I think we all are looking for, to show we know it's urgent. how do we communicate to others its urgency? I don't have the privilege of treating people. I have the privilege of trying to figure out how to get policymakers' attention on this. And that, so there, I think that has actually really been, I think, a wake-up call. And has, I think, led to, from where we sit as World Obesity, greater attention to obesity and to its complications and comorbidities like NASH and NAFLD. And UNICEF and WHO are working with us on launching a new coalition, a global obesity coalition, which is great, so that we can align efforts. And I think also UNICEF is a great example of, they're an agency that's starting to really put a lot of focus on childhood obesity, and that in turn, I think, becomes a great entry point for bringing NASH and NAFLD into the equation with them as well. Pragmatically, to answer your questions, though, I think, first of all, telehealth has been great. I also am a person living with NCDs. I've had multiple sclerosis for 30 years, and I've been in remission for a long time, but doing all my visits via telehealth was wonderful. Time saver, simpler, I think, and then, just other health issues, family health issues, it's great. But I think the only other thing is there's some great examples of approaches to change that obesogenic environment that many children are growing up in. In Amsterdam is well known, the Jump It program that really was a great example of the city of Amsterdam. Things work more easily at a city level. They brought all the key actors together because they're all sitting inside City Hall, and created sort of agreed upon targets and a comprehensive approach, very much centered around schools, but not limited to that. Those are, there's examples like that. And other initiatives through WHO's Ending Childhood Obesity Commission, the ECHO Commission's recommendations, which are being rolled out and implemented in many countries all over the world: physical activity, changing the food environment, addressing prenatal care and the weight of the pregnant mother, of course, and then making sure that there's management in primary care as well, which I think, as you mentioned, there's a lot of barriers to the people who need that care getting it, and overcoming that myth of personal blame is an incredibly important part of that.
I want to pick up on you made several great points there. I want to pick up on a few. So how early do we need to start? Do we need to start talking with women when they're pregnant, or even preparing for pregnancy, and reaching out to your obstetrician and your pediatrician colleagues? Are you having those conversations with OBGYNs and pediatrics? Are you starting to have those around NASH?
I'm sorry. Well, World Obesity Federation, I would just say we focus on breastfeeding as well, just to make sure that the child, that's an element. But I'd love to hear from the doctors.
That's great. From our hepatology, side, are you finding receptivity to outreach by your colleagues in pediatrics and obstetrics?
So there are increased awareness over the last few years. So we acceptance is, engagement is much better than it used to be initially. There are lots of studies showing that maternal weight is a risk factor for infant obesity and long-term obesity-related health issues. So this is a well-known problem, actually. And there are so many interventions that can be done during pregnancy to improve the outcome of the pregnancy and the outcome of the newborn and infant. And there are studies showing that, for example, Mediterranean diet during pregnancy has some benefits. So I think our colleague in obstetric are more aware, and they are watching obese, women with obesity, as Joanna told us. I'm going to use this terminology. I love it. Closer, and those, some of them might qualify as high-risk pregnancy. So I think the awareness and the engagement is better now. We can do more always, especially in the underserved population, patient with social challenges. It goes back to the equity that we spoke about earlier. So this is where we are right now. But it's well known that the ramification of having a mother with obesity on the infant can last longer and longer and is a risk factor for rapidly progressive NASH in childhood.
So at Penn or at Duke, do you do any joint activities with your pediatric or obstetrician colleagues, or can we host some?
We don't currently do anything at Duke, but I think we should. I work with an adult hepatologist, Dr. Cindy Moylan, who's really looking at the epigenetic risk factors of maternal obesity and pre-pregnancy BMI and those risk factors on pediatric NAFLD and NASH. And even looking at some of the changes that happen in the DNA methylation in patients that were born to mothers that had a pre-pregnancy obesity BMI of greater than 30. So we have not engaged from a pediatric side yet. I know from the adult hepatology side, she has. I think it's an area for opportunity that we need to actually go after, because you really need, as you mentioned earlier, you need to start thinking about the obesity side when you're thinking about getting pregnant, not after you're pregnant or once the child is already born, but when you're planning a pregnancy, obesity should be part of the discussion of that. So I think we could do a lot at the Duke, and we need to start expanding on it and going after it.
Jennifer?
Yeah, I agree. Recently I just reviewed an article looking at like hepatic steatosis that's identified early in infancy and looking at the association with pregnancy, obesity, like what are the other risk factors? So I think, it's identified early on. The question becomes, is it truly because of the obesity in the mother? I mean, is it because of obesity associated, or is it the change in the gut microbiota? Because I'm a gastroenterologist, so I have to mention that. And the other risk factors. So I think it's a combination. I do feel like we need to, I haven't personally engaged our OB group, but, like Dr. Mavis, I've collaborated with Dr. Donna Cryer over at Penn, who we've discussed this multiple times and looking at like, what are the risk factors and trying to see, like, does it start in the womb? Or does it even start prior to that? And like what happens over time from pediatrics into the adult world? So it's something we've talked about, but like Dr. Ed Mavis had said, I mean, we should really try to engage them and see so we can get more data and figure it out, right? But I wanted to add something to what Joanna said, mentioned a while ago. I mean, having NASH is 2 to 3% increase in mortality. Like it's an independent risk factor. I think people think about NAFLD, NASH as a singular disease, but really how I see it now, I see NASH in our IBD patients. I see NASH in our CF patients. I see NASH in like all REMS. My other like subspecialty colleagues always refer to us, and like the terminology that we think about now is like MAFLD, right? Metabolic associated liver disease. There is a strong association with diabetes, insulin resistance, and other risk factors. So I think, it's just not liver disease anymore, is like how I think about it, right? So it's great that we have this collaboration, and to even think about it earlier on with our OB colleagues would be phenomenal.
Well, okay, I'll put that on my personal to-do list here. We've talked about, and you've mentioned different research gaps and questions we don't quite have the data or the evidence to be able to answer or to present to policymakers. And so I'd love for each of you, from your own perspectives, to tee up a few research questions that we would need to fund and follow. What would you like to know more about? Microbiome is one thing, and I'm very intrigued by that as a patient with IBD. So Jennifer or Alisha or Samar, top research questions in this field that you'd like to pursue.
Sure, I can start. It's as it's on the mind of everybody. We need non-invasive biomarker for NASH. There are a lot of work on this area, but if we reach a point where we don't need to do a liver biopsy because this is always on the mind of patient, it will be great. And there are emerging studies supporting some tools like the MRI, the multiparametric MRI. There are some blood biomarker, but this is an area that's still in need of research, this one area. And the other area is to have a cure for NASH, and it's accepted now. It's not going to be a single agent. It's going to be a combination with lifestyle intervention still on the table, but try to address NASH as Jennifer and Alisha and Joanna said from different perspectives, including finding a mechanistically, based therapeutic targets.
I like that. Non-invasive having had 6 liver biopsies myself, I'm firmly in the non-invasive diagnostics camp. And we were even in our NASH and lean individuals conversation talking about and this is in adults, use of the tape measure and waist circumference is the ultimate non-invasive diagnostic when you talk about scaling screening to rural communities and many countries. And so I thought that was intriguing because we're always, I think in the US, so high tech and, have access to so much, really thinking about how non-invasive can non-invasive be? How simple can we make this? How clear can we be about the risk factors to assure that everyone who has NASH is diagnosed well before they end up, being told they need a transplant or develop into cancer or something like that. So other research questions, Jennifer?
I like to add on to the waist circumference. So as I did a study as a fellow and we looked at, metabolic syndrome and NASH, and I had to measure all of my patients and doing the waist circumference, and, like central obesity increases your risk, right? So I think that's a great idea. But, like Samar was saying, like one of the biggest things I think the push for is like non-invasive techniques and treatment, because in terms of the adult world, I just had a joint conference with, our adult colleagues, and they've gone away from biopsy, right? So it's hard. We have a transition clinic at CHOP at Penn, and it's very hard for my patients to be like, oh, I'm 17. If I go over next door, they're not going to biopsy me. But here, if I want to do some type of therapy, example, if we were to start some medication for weight loss, I require a biopsy. And I do that because in pediatrics, it's still hard. The risk benefit ratio in trying to initiate any therapy based on the AASLD guidelines and the NASPGHAN guidelines, if you're going to, if it's a potentially hepatotoxic medication, you do have to do a biopsy first. So I think so my push would be to do something non-invasive. And that's what I'd really like to study, because our adults do a fibroscan with CAP technology, where they're able to assess the amount of inflammation in addition to what's the steatosis scoring. And that's been really good in their end. So they've gone away from it. A lot of other pediatric centers, if you're lucky, does have that capacity to do that. Fortunately, ours is in the research realm and we're not doing it clinically yet. I don't know if Alisha has that capacity over at Duke, but we're not quite there yet. And then for treatment, I mean, I'm pro lifestyle intervention. I focus on that, but it would be nice to give my children an option. You're in this, if your BMI is 40 and and you don't want bariatric surgery, like what can I start you on to jumpstart that process to help, with your fibrosis that's already present and you're only 10 or 12, right? Like, how can I help you in a different aspect that, you need at least 10% like weight loss from your baseline, your kind of upper body weight to really lose and improve your NASH. And most kids don't have the capacity to do that unless, and I've been successful with some of my patients because we have a multidisciplinary clinic, but for some other people who have one gastroenterologist and don't even have a dietitian, unless the family is phenomenal, it's really hard to do those interventions. So my push is research also in that realm.
Great. Alisha?
I do agree with Samar and Jennifer about trying to find non-invasive biomarkers or ways to diagnosis, as a liver biopsy does have risk and benefits. But some of the other areas, I think treatment is hugely important. But we have a few drugs in the pipeline that are looking like they're coming down. But what are things that are not medicine related? Can we start doing exercise prescriptions? It'd be great if we could, get everyone out to the park, but that's not how neighborhoods are, and it's not always safe to be outside. But are certain types of exercise work better for certain individual? Is there a specific phenotype for that individual's NAFLD or NASH that certain types of things would do better that we could prescribe them to do at home? And I think some of the other things we have to address, and it's not the research side. The research is there showing that lower fructose corn syrup and increased fruits and vegetables and lean meats and the Mediterranean diet do great. But how do we address that from a policy or from a governmental perspective to where people have access to all of that? Being down in the South with the pandemic recently, one of our biggest things was food insecurity and all the food deserts. And yes, the schools eventually started opening up to provide lunches for a week for these families, but you could only go between 11 and 1. And if many of our patients that needed those lunches, their family member couldn't take off work at that time to go pick up the food that was needed. And so they're relying on the food banks, which have highly processed food, not much fruit and vegetables. I'm very jealous of Jennifer's group having the food pharmacy. That sounded like an amazing
that we can
opportunity. Yeah, I mean, I got to learn more about that and see if we can get that down here. But so the research is needed on treatments, non-invasive ways, but we also need the policies of how do we provide access to the dietary changes that are needed that have already been shown by research that are necessary to treat this and to help with it. So
Joanna, that tees you up. What evidence gaps do you see that are hindering you making the fullest throatest argument to policymakers about the importance of integrating NASH into your work in NCDs and really just making the case about the impact and the urgency of NASH along with the other conditions?
Well, it's interesting because in a way, my response is more that I think what is needed is almost when you operate at a global level and are trying to get support from every country for something, it's what's the technical package? What are the priorities? And in a way, what's the guidance? Not guidelines, but guidance. And particularly as they integrate with obesity and across obesity, cardiovascular, and diabetes, where I do see there's a ripe opportunity for greater integration and coordinated advocacy on this. So it's essentially what elements, and just to, as an example, with World Obesity Federation, with the global obesity community, we came up with something called ROOTS, which each letter stands for what your package needs, what your integrated approach needs, what your ask of government needs, and doing it in an acronym really helps simplify complex issues. So R is recognize obesity as risk factor and disease. Each of the O's stands for, one is monitoring and surveillance, the other is life course. The T is treatment. S is systems, meaning food systems, health systems, urban planning systems, all the systems that contribute. And in a way, I think that NASH is perfectly positioned to define something like that as well. Or there's an opportunity to try to say, what are the 5 things we want? Different countries, different constituencies choose to emphasize different parts of those 5 things, but those 5 things are what it takes to effectively address NASH. So that's how I would answer your question.
I think that's absolutely, I think that's helpful. We've been working with our own Centers for Disease Control and Prevention about being able to provide more detailed and comprehensive data on NASH overall across its various divisions, because there are implications in cancer and the obesity, in diabetes. We worked with divisions we worked with very closely to really get a full picture on NASH and fill in some of the gaps on children with NASH in particular. So if we have good data, then hopefully we can make good policy.
Great.
But you all have given me a lot of food for thought. I think everybody who is watching or listening has learned so much about pediatric NASH or NASH in children, and what we all need to do, or what we all can do to help support children, families, communities, and countries to be healthy. So thank you so much. And for information on our other panels on International NASH Day, and all of our fabulous information, videos from the WHO, from various medical societies, and our culinary event this evening, please follow us on Facebook, on Twitter. We're Global Liver Institute on Instagram. Use the hashtag NASH Day to follow us throughout the day, throughout social media. I thank you. Stay well, stay connected.